The stuff we're going to cover in this video seem to indicate more about Schreier's personal interpretations for why somebody would want to transition, like getting rid of tricky fat deposits, rather than the actual reality of the reasons why people transition. Surprise! This video made possible thanks to continuing support of viewers, patrons, and PayPal pals like you. Thanks! Hi! Welcome back to This Cognitive Psychologist's Gradual Loss of Faith in Humanity as we continue Abigail Schreier's Irreversible Damage. Notes for this video. First, a reminder that Schreier tends to go with the gender assigned at birth sort of language, irrespective of what the person's gender identity might be, and we're not about that on this channel. So for on-screen quotes, when you see square brackets surrounding gender-neutral language, I've changed it. Second, a citation needed flag doesn't necessarily mean that I'm disagreeing with what's being said, just that's a statement that needs some sort of support. Ideally, something that's been peer-reviewed and not just a blog post. Third, something that pops up more and more frequently is the gender-critical language, transgender identified. This language acts to delegitimize the trans and or non-binary person's gender identity. The idea behind it seems to be that they aren't really trans and or non-binary, they just identify that way. Finally, just a complaint, really. Schreier's referencing for things at this point include a fair number of dead links or general typos, and that makes me cranky. Anyways, last thing is a quick refresher for the visual shorthand indicating where ideas are coming from. This means I'm paraphrasing the book. This means I'm responding to the book or integrating my thoughts with science. Sometimes. It's also where we'll discuss Schreier's endnotes. Yay! Alright, let's get to the hormones and surgeries. To spoil things slightly, Schreier's basic point here is that these youth are self-medicating anxiety and or depression instead of getting the proper medications to treat those, or good old-fashioned sucking it up, as alluded to earlier in the book. But to reiterate the counterpoints, gender dysphoria is not the same thing as anxiety and or depression. Gender dysphoria is not mutually exclusive with depression or anxiety, and a person need not experience gender dysphoria for their gender identity to be valid. With that out of the way.
If, as Arthurian legend would have it, self-determination is every young woman's fondest desire, then testosterone is not a bad way of obtaining it. Testosterone suppresses anxiety and even lifts depression. It makes young AFAB people bold and unafraid. For the socially inhibited, the freedom it offers can feel like nothing short of a miracle.
Flowery language aside, is she saying that testosterone is like a cheat code for feeling like you have control over your life? Reference 11 is a review paper covering the effects of testosterone on behavior, with a mixture of animal and human data. There's a lot covered here, from anxiety and depression to more cognitive things like memory or spatial abilities. But, to quote from the paper's conclusion, while fMRI results bring interesting data and knowledge on behavioral traits and spatial abilities in relation to testosterone levels and sex differences, the result obtained can only show association or correlation but not causal relationship of testosterone effect on behavior. So no, Schreier, this paper doesn't support the argument testosterone can do these things. The most we can say right now is that there is some relationship between testosterone and these states.
Of course, it can also lessen short-term memory and increase moodiness and irritability, but that's someone else's problem. Was I rude or pugnacious? Sorry, it's just that I feel so good.
Interestingly, Schreier's reference 11 doesn't support her memory claim here. I did a little poll on Twitter and YouTube for people's experience who have taken testosterone. Of the roughly 400 respondents, of the 4 options available on Twitter, the highest rated option was no real change in perceived mental acuity coming from testosterone. For the YouTube poll, there was a sampling issue where at least some people were voting options not capturing experience to be able to see poll results, and I'm not sure how many people did that. The next most common response was that they felt more clear after starting testosterone. In the comments, some elaborations on this were that the gender dysphoria eased up, which had been taking up some cognitive resources, or they started some other psychiatric prescription at the same time. Granted, this was not a random sample and is anecdata, but at the very least, Schreier's causal effect of testosterone isn't fully capturing people's experiences. But taking a step back and thinking about this for a second, if testosterone had these effects at naturally occurring levels, roughly half the cisgender population would be at least somewhat functionally impaired a good chunk of the time, which they don't seem to be. And also, Schreier is overstating the effect on mood.
And then there's the hateful mirror, every adolescent AFAB's foe. Testosterone redistributes a young person's fat away from all those places that give them so much consternation. Thighs, hips, bottom. That cruel pageantry of online body shaming no longer holds relevance for them. No one examines a boy's photos for thigh gap, muffin tops, cottage cheese. Within the first few months of injections, as body and facial hair begin to sprout, it'll be clear that they're done serving up their body for ridicule. They're on the boys' team now.
It seems like Schreier thinks that only AFAB youth can get body shamed. It may not be quite to the same degree, but boys and men also get a fair amount of physical scrutiny, albeit not for the same things. How tall are they? How muscular do they look? Can you see their abs? How strong is their chin? Where's their hairline? And so forth. It's like her only context for why someone would want to start testosterone is to fix what are perceived to be problem areas for women. But the tricky thing with that even is that one of the beauty standards right now is for women to have just the right amount of fat in particular areas, giving rise to the Brazilian butt lift. Implying that trans men or boys also don't receive a lot of scrutiny is patently naive, especially with things she has to say later this chapter.
Testosterone comes in a variety of forms, including gels and patches. But if you're up for something really edgy, there's also the self-administered intramuscular shot. This testifies to the world loud as stentor that you're nothing like your mother. You're not even a girl, and you're not messing around.
Schreier elaborates by saying that the plethora of YouTube videos on injecting testosterone indicate that this is a joyride that you just have to tell the world about. She quotes a YouTuber who says he's happy with the decision to take testosterone, but notes that it didn't solve all of his problems, although it did help with some things like social issues. Schreier cut off this quote before this YouTuber continued on to say that he knows he still has some problems he needs to work on, and also he's hit a bit of a depressive slump because the transition to-do list has mostly been checked off. There's a sense of, now what? So, less a joyride and more a balanced reflection on what his experiences have been on testosterone for a couple years. But back to her bigger picture. So much of transition in Schreier's mind is social signaling, but in a way that misses the point. My understanding of people undergoing transition is it's a complex thing. There is the part of it that involves signaling to others that you are a certain gender, but there's also the part in trying to get the internal sense of self to feel right. I'm also not sure if the administration route buys somebody a higher spot on the dude-bro hierarchy. There's a little bit on the increasing number of gender identity clinics in the US and how many of the places will give testosterone at the first visit at whatever the age of medical consent is. I was able to get hormonal birth control without my mom finding out at 17. I probably could have done it younger, but I didn't need it until then. Like many hormonal treatments, there are potentially some nasty side effects, like blood clots. I was willing to take on that risk because I didn't want to get pregnant. I'm sure Schreier would counter-argue my point by saying that I wasn't irreversibly changing my body and taking birth control. And sure, I wasn't. The changes I experienced were temporary. But back with the gender-affirming hormones, what treatment option is doing the least harm? Would it be better to have trans and or non-binary youth suffer through an adolescence and physiological changes that they'll later have to fix to prevent the roughly 0.5% of people who had transitioned but come to feel it wasn't for them transition? Or would it be better to listen to people when they say they want a particular treatment with the knowledge a very small subset may change their minds? The current standards of care err on the side of preventing harm for the majority of people while accepting that a small minority may detransition down the road. Schreier relays the story of Helena, who started testosterone in high school. That name may be ringing a bell. Way back in Chapter 1, Schreier included a Fourth Wave Now blog post from Helena about Tumblr. Helena will also be a large part of the next chapter, so we'll move on for now.
Sure, the clinic informed Helena about some of the risks, though not the painful vaginal atrophy she would suffer. But how do patients ever assess the risks? Does anyone read those forms? In any case, most trans-identified adolescents are more than happy to accept them.
Okay, TMI time, because what is this channel if not me oversharing? As mentioned, I started hormonal birth control as a teen. The major risks were discussed, like blood clots, but the more uncommon or less severe weren't talked about. So when I was super tired and just feeling absolutely sick to my stomach in the mornings, I didn't really think anything of it. But gradually, super gradually, sex got to be painful, to the point where any internal friction felt like tissues were just ripping. After seeing a handful of nurses and doctors over the course of about half a year, I finally made it to a specialist who said, "This looks like it's hormone related. And hey, there's an estrogen replacement cream that would help with that. Or stopping the birth control," which is the option I went with because I was losing my health insurance soon after. Problem solved. I bring this up because I looked up the symptoms for vaginal atrophy and it sounds about right from my experience. I've been there and it sucks. Had I known this was a risk for birth control, I still would have tried it. I just would have known what the fuck was going on with my body and been spared a lot of time, money, and pain. Having to possibly deal with that was a worthwhile trade-off for being extra sure I wasn't going to accidentally get knocked up. And I'm sure that that's a trade-off that many AFAB, non-binary, and/or trans people are willing to make. Schreier shares another quote from her interview with the YouTuber she focused on in the influencers chapter, where he says taking testosterone puts him at the same risk, roughly, for heart attack as cisgender men. And then, of course, she has to go somewhere weird with it.
He believes testosterone merely took him to the level of cardiovascular risk that he should have been born with, had he been born in the right body. Put another way, health risks are another perk, like that tattoo that brands you a member of a gang. If you want to become a man, you have to expect to be strong like one, horny like one, and yes, prone to a heart attack like one.
I highly doubt that trans and or non-binary people on testosterone view the increased cardiovascular risk as a feature and not as a necessary evil. Like, if it was possible to get the testosterone effects without that risk, I imagine that would be the option people would go with. Reference 12 has me questioning if Schreier actually reads these. It's comparing the mortality data of the general population against transgender people. For the trans men, the mortality rate was about the same, if not lower, than the general population. There was one heart attack for a 72-year-old who had been on testosterone for 42 years. What the hell, Schreier? Schreier repeats herself, talking about how being on testosterone will make fat deposits move away from feminine areas, while neglecting to mention that it shifts to places like the stomach, making you foggy and less able to reevaluate being on testosterone. Please refer back to my previous poll results. And also making depression and/or anxiety symptoms drift away. Okay, let's do a little sciencing here. There is a link between a trans person being on gender-affirming hormone therapy and an improvement in mood, anxiety, depression, and general functioning. However, the authors of this review paper note that there isn't research on hormonal therapy and general cognition. There's stuff comparing trans people to their cis counterparts for brain activity and whatnot, but not if there are specific improvements in things like executive function. Also, specific to trans men, there isn't conclusive evidence that anger or aggression increase in a clear way from the testosterone. But to really drive this home, the testosterone itself is not directly linked to the improvements in depression and anxiety. There's a whole slew of factors there, like gender dysphoria easing up, improved self-confidence, generally feeling right in their body and mind, and so on. I'm emphasizing this because of where Schreier's going next.
Many of the AFAB youth caught up in this epidemic may be unconsciously self-medicating. They call their distress gender dysphoria, but what they may be treating is anxiety and depression. Most have battled one or both.
Schreier has a long way to go to support this claim. Schreier discusses some of the changes an AFAB person can expect on testosterone, like changes in voice pitch, hair distribution, musculature, and so forth. She draws a parallel once again to people with anorexia, saying that both will fixate on themselves watching the changes in the mirror. And then, because it always has to come back to the dicks with her, talks about the changes to the clitoris as well as sex drive. She claims sex may be limited to DIY activities because of vaginal atrophy or becoming hyper-conscious of their body changes. Reference 13, correcting for the typo in the book, is a paper reporting the results of a self-report survey of trans people and their sexual functioning several years after entering treatment. People are split into trans men and women, but in the demographics under gender identity, there are more categories, so that's where that is, I guess. Looking specifically at trans men, The majority have no problem. The darker gray is for self-reported no problem with the different possibilities. The light gray indicates some functional problem without distress, and the black means there is dysfunction and distress in that category. There are some men having trouble starting up a sexual relationship, with fewer being afraid of sex, avoiding it, experiencing pain, and so forth. I'd be interested to know what these figures would be for cisgender people. As described in one of the earlier instances of my body flipping me the bird, I had a stretch where sex was painful. And even with that fixed, there are still instances where things get poked at a weird angle and it hurts. I bring this up again, not to minimize the experiences of the survey takers, but to counter Schreier's claim that these problems are entirely unique to trans men. Our bodies can be finicky in their responses to stuff, and we can have positive and/or negative feelings about them. Just the specifics for the root of those feelings can vary. Not wanting to get undressed in front of somebody, for someone, it may be gender dysphoria. For somebody else, it may be body dysmorphia.
Whatever euphoria these AFAB youth are chasing, it stops short of helping them achieve physical connection with another person.
I don't know who she's been talking to, but that's not what I've been told. The rest of this chapter really feels more like Schreier writing about why she would consider transitioning more than reality.
The greatest thrill of all may be that of disguise. Remember the boy who dumped them? The ill-considered nude selfie, which made its way to his several hundred best friends? All those stupid things they did back in middle school, captured in digital images and spread among their peers. The clique that locked them out, then tormented them with an endless online exhibition of how much fun its members all have without them? The doctored photos of them some kid created as a prank, and made sure everyone saw? The hand that mocked them, and the heart that fed. Well, the joke's on them. They're done feeling bad. Everyone can see. That's not them anymore.
Let's start this by saying that I'm glad I grew up before the digital age became what it is. The embarrassing photos and videos of me from when I was younger are not digital, and the bullying I experienced from people I considered my best friends stayed in the real world. Bullying has evolved to keep pace with technology, and that is horrifying for kids today. I highly doubt you can put the drive for AFAB youth to transition at the feet of bullying. Even flipping back through the stories from parents Schreier has shared makes no mention of the youths having been bullied at any point. None. We start this section with a weird paragraph, where it seems like the subtext is making a claim that isn't grounded in reality. Schreier starts by talking about the trans YouTuber she'd interviewed, saying,
He wasn't quite right. The 9 years he has spent on testosterone may have conferred something more than the cardiovascular frailty of a biological man. In fact, it may have made his risk of cardiovascular disease much worse.
This reference has me very seriously questioning if Schreier understands anything at this point. And note 14 has 2 references. The first looked at the risk of venous thromboembolisms, ischemic strokes, and myocardial infarctions in transgender people compared to cisgender controls, specifically from hormone use. The controls were matched for age, ethnicity, and location. They found that trans women had a higher incidence of embolisms than cis men, cis women, and trans men. They also had more strokes. They didn't really find any differences for trans men. As I mentioned earlier, estrogen carries these risks. It isn't surprising that trans women who are taking estrogen would see an uptick in these negative side effects, and this is something that trans women and their doctors should stay on top of. But this reference in no shape or form supports Schreier's claim that this trans YouTuber's risk of heart disease is so much worse. What is she even doing at this point? The second reference in 14 used data from the Behavioral Risk Factor Surveillance System, a US survey by state health departments, to compare cardiovascular disease risk between trans and cisgender people. This study did find an increased incidence of myocardial infarctions in trans men compared to cis men and women. Trans women also had a higher incidence than cis women, but not cis men. However, as noted in the linked editorial, there are some limitations. First, causation cannot be determined from the study. All we can know from the data is that there were trans men and some had infarctions. The hormonal therapy is inferred from their gender identity. Second, there is a lot more going on in the average trans man life than hormone therapy. The higher risk of unemployment, homelessness, risky behaviors in general, and greater stress all also play a role in heart trouble. Third, While some attempt was made at separating out individuals who are non-binary, it's not clear that they were actually able to do so. Also, similar to the first point, it's not clear what hormonal treatments they had used, if any. So yeah, there may be an increased risk of cardiovascular disease for trans men, but the cause for that is far from clear. What are you doing, Schreier?
Testosterone thickens the blood. Transgender-identified AFAB people are given a dosage of testosterone 10 to 40 times greater than their bodies would normally bear to produce the changes they seek.
Oh look, an endnote. Oh, this is literally just a note about the testosterone levels from PCOS, also without a citation. For fuck's sake.
There is some indication that biological AFAB people on these doses of testosterone may have nearly 5 times the risk of heart attack that women have, and 2.5 times that of men.
Endnote 16 is the second reference from 14, the one that found increased infarctions in trans men but inferred the use of hormones. It also has a comment from Schreier about what the gender-critical endocrinologist told her about one of the figures. And yeah, in this data, trans men have an increased risk of myocardial infarction. The story gets a little more complicated when you look at the year-by-year data. It seems somewhat variable from year to year. But again, this study is inferring hormone use based on gender identity. We don't know what anyone was taking or for how long. We also don't know what their life context is. Schreier says that dosage is based on aesthetics, and so isn't guided by medical principles. And because endocrinologists track blood levels of testosterone and not the person's gender dysphoria, they're acting more in line with hairstylists than doctors. Weird that an endocrinologist would stay in their training lane and let a mental health professional take the lead if the patient has gender dysphoria. Schreier points out some of the irreversible changes that take place from the testosterone treatment that won't reverse if the person stops the hormones.
There are also pains and inconveniences that come with testosterone. We've seen that vaginal atrophy is a problem. There are also muscle aches, painful cramping due to endometriosis, increased sweating, moodiness, and aggression. The long-term effects include heightened rates of diabetes, stroke, blood clots, cancer, and as we've seen, heart disease. In general, mortality risk rises.
The endometriosis point has me the most curious, so let's take a look-see. I could be missing something, but I'm only really seeing that testosterone can be used as a treatment for endo, as it helps prevent the uterine lining, errant or not, from doing its thing. Also, low testosterone levels in menstruators may play a role in endometriosis itself. The rest of this list, some things sure, probably, others not so much. And as previously discussed, the weight of life circumstances cannot be ignored for a lot of the health concerns. Then comes an ass pull, so monumental, a doctor friend gave it a what the fuck?
There is one last but inevitable risk, brought on by the fact that no patient on Earth takes every dose of their medicine precisely on time. At some point, a young person on T will give themselves a shot a day or two after they were supposed to. In an AFAB person not on testosterone, the fast-growing uterine lining is managed by their pituitary, which either halts its growth for the sake of a placenta or directs the lining to be shed in a period. Testosterone shuts down the signaling, turning a person's menstrual cycle off. When a person forgets to take their testosterone on time, their ovaries will stimulate sudden spurts of fast-growing uterine lining. This could heighten risk of cell mutation and endometrial cancer.
Well, that was said. Dr. Friend did me a research and passed along an educational booklet about the known cancer risks for the trans population. While there are concerns for the trans population's cancer risk because of things like the generally marginalized status of the group, high use of cigarettes and alcohol, and the medical system still figuring out how to address and serve trans people's needs, there's nothing like what Schreier said included here. I'm also not finding this proposed mechanism she's talking about. If anything, testosterone might help reduce what Schreier seems to be talking about here. But the jury is still very much out on this topic. Moving on. Schreier says that this risk of uterine cancer means that people are encouraged by their doctors to get a hysterectomy and oophorectomy after being on testosterone for 5 years. There are 2 references in EndNote 18. The first is where she's getting this 5-year figure from. This is a summary of medical treatment protocols for trans and/or non-binary people. It doesn't lay out why the recommendation for hysterectomy and oophorectomy is made at 5 years, but I'd hazard a guess that's because those organs are a liability if you aren't intending to use them. And since we don't totally know the long-term effects of testosterone, better to be safe, especially as it simplifies treatment. The second of Schreier's references is from an author I cited in the discussion of Schreier's proposed cancer mechanism. She quotes a large portion of the conclusions, including the authors noting that the association between some endometrial lining potentially persisting on testosterone and endometrial cancer is not known. An unknown risk, which is something that should still be studied and figured out if it is known or not, does not make it a suspected risk. But if you've been watching the series for a bit, you can probably guess what Schreier's actual problem with this is.
Whether by way of Lupron or straight to tea, the end of this story is sterility. These young people have wagered their identities, names, and bodies on the promise of a fresh start, and testosterone arrives like a Rumpelstiltskin to claim their fertility for good.
Yep, the bottom line problem here isn't the cancer risk that may or may not pan out, it's that these people are removing the ability to produce offspring. Except for the part where Schreier's apparently missing the trans and or non-binary people who have born children. Nothing like threatening the reader with the potential of their future grandchildren to get them on board.
After all this risk and untold sacrifice, at least their gender dysphoria is gone, right? In fact, there are no good long-term studies indicating that either gender dysphoria or suicidality diminishes after medical transition.
And Note 19 has 3 citations. First is an article in the Catholic Medical Association's journal, the Lincare Quarterly, from endocrinologist Paul Hruz. I think it's worth mentioning that Hruz has also been associated with the Heritage Foundation, and despite being at the prestigious WashU, that university has confirmed that Hruz is not, quote, an expert in transgender health, is not a psychiatrist, a psychologist, nor mental health care provider of any kind who could speak knowledgeably about transgender health. So this all is a bit suspect. Next. Second is a reference Schreier used in Chapter 6, The Therapists, in the same argument. As we covered in that video, this paper covers Swedish data ranging from the 70s to the early aughts. The risk of a person ending their life has dropped since the late 80s. The authors explicitly note that treating gender dysphoria will not treat other psychological disorders, like depression or anxiety, and as such, those need to also be addressed. Also, as previously discussed, more recent work by the lead author found lower suicide attempts after gender-affirming treatment. The third reference compared psychosocial functioning before and after psychological support and puberty blockers. They found better psychosocial functioning after both. Schreier references the second page of the paper in particular. I'm guessing the paragraph that describes research where adolescents with gender dysphoria don't markedly improve from psychotherapy alone. This is nestled between adults being helped by cross-sex hormonal treatment and adolescents not thriving after having to go through the puberty assigned at birth. Schreier's reading comprehension, or seeming lack thereof, strikes again with that last one. Altogether, no. Moving on to the next argument. Schreier argues that an AFAB person's gender dysphoria will actually increase after being on testosterone because they still won't look exactly like a man, referring back to the stuff upstairs. This acts as a transition between this section and the next, with her detailing the problems with binders again, and that top surgery is a long-term solution. This section starts with Schreier talking about an infamous video of Dr. Joanna Olson Kennedy, the medical director of the Children's Hospital of Los Angeles' Center for Trans Youth Health and Development. Schreier describes a possible scenario for how this video was filmed and comments on how Olson Kennedy is dressed, saying, quote, her blonde hair is messily tied back in a loose bun. She's wearing a stretchy outfit, camouflage green shirt and black pants that could pass for pajamas. She looks more like a co-ed caught prepping for finals than the recipient of the National Institute of Health's first grant, $5.7 million, to study the outcomes of medical treatment of transgender youth. Looks more like an average blouse and dress pants combo to me. This video is infamous because of the part where she is recorded saying,
what we do know is that adolescents actually have the capacity to make a reasoned, logical decision. And here's the other thing about chest surgery. If you want breasts at a later point in your life, you can go and get them.
It's a shocking statement. The sort of things parents of these AFAB youths send around to each other to prove what sort of monstrous ideology they're up against. Doctors can't really be that flippant about recommending youths for double mastectomy, can they? Surely someone who believes in recommending AFAB youths as young as 13 for top surgery, as Dr. Olson Kennedy does, takes their responsibility quite seriously. Surely such doctors recognize the patient's profound loss, even if they ultimately recommend it?
Schreier said one of the quiet parts out loud here. Monstrous ideology sent around by unsupportive parents. Schreier contacted Olson Kennedy and teases at this point that she's saving that for the end of the chapter. We're going to talk about it now. Schreier sets up this engagement as providing Kennedy Olson a chance to add context, nuance, or possibly even retract what she said in that video. Schreier indicates that she emailed her, saying she was, quote, writing a book on the sudden spike of transgender identification among adolescent youths with no history of gender dysphoria. Olson Kennedy responded quickly, asking if Schreier wrote for The Federalist. Schreier clarified that she had, but now freelances, mostly for the Wall Street Journal. She repeated the request to talk to Olson Kennedy with the described goal of understanding how the video didn't reflect her views, but never heard back. Then Schreier talks about Olson Kennedy's email signature and how it indicates that doctors have become activists. I also reached out to Dr. Olson Kennedy as a lot of this seems sus because, frankly, I don't trust Schreier to fairly describe somebody she considers an activist. While Olson Kennedy did respond to my email and was very nice in doing so, she politely declined answering my questions about all of this, in part possibly not to give Schreier more ammo given the toxicity of the space. So we're just going to take a closer look at this video Schreier included. Schreier's reference 23 is to a short video posted on the YouTube channel Is This Appropriate Treatment? This video's description doesn't really identify where this talk happened, just that it was in July 2018. There's also a link to the full video, also on this channel. The full-length video's description box says it was, quote, recorded at the Professional Symposium convened by the Gender Spectrum Child Transing Organization. Super helpful description. Exactly how you would see it on somebody's CV. As I mentioned, I wasn't able to ask Olson Kennedy about the context of this talk, so we're going to work with best guesses. This feels strongly reminiscent of many talks I attended in grad school. It's Olson Kennedy breaking down her paper, Schreier's reference 24, then fielding questions. This looks like it's taking place in a classroom with people surrounding the covert filmer taking notes. I would guess that most people attending this talk would fall into one of three camps. Either grad students of some form, from the questions asked some active practitioners, and the general public. The distilled version of the question that led to the smaller clip was in the context of a therapist having conversations with parents who are worried about their kid having top surgery. At what point can the medical team know that it isn't just a phase? The part of the short clip that Schreier didn't quote is Olson Kennedy talking about all of the things we trust adolescents with already, like driving, picking colleges and majors, potentially getting married, and so forth. She adds that we tend to focus on decisions where teenagers do a dumb, like the cinnamon challenge.
But we don't put on YouTube the things that are really good decisions, right? Oh my gosh, my kid took the SATs. Not a very exciting after-school special, right? But so what we do know is that adolescents actually have the capacity to make a reasoned, logical decision. And here's the other thing about chest surgery. If you want breasts at a later point in your life, you can go and get them.
Okay, so we know a little bit more for the context of that comment. Let's look at the paper. This looked at chest dysphoria in AFAB youth, ages ranging from 13 to 25 years old, comparing those who had chest reconstruction surgery with those who had not. They also looked at rates of regret or other negative outcomes from the surgery. As shown in Table 1, there seemed to have been lower chest dysphoria for those who had undergone top surgery, as indicated by lower positive endorsements for the negative items of the chest dysphoria scale. Table 3 includes complications reported by those who had the surgery. Most common was temporary loss of nipple sensation, followed by some loss of sensation in the chest area, then 22% reporting long-term loss of nipple sensation. A point not included in the tables is that all post-surgical participants agreed with the statement that it was a good decision to undergo chest reconstruction. As noted in Olson Kennedy's talk, one participant indicated sometimes having some regret about the surgery he had received as an adult. In the talk, Olson Kennedy explains that this person was concerned about potential effects on chest feeding as he was interested in having a child. This was explored with the medical team in multiple sessions, but the dysphoria was ultimately too much and so he had the surgery. Olson Kennedy mentioned that he's since had a child and things have been fine. In closing, this study found very low levels of regret for top surgery, even when the patient was a minor. It's also emphasized that chest dysphoria can have a health impact, because of the binders as well as avoiding medical care because of how their chest looks. So yeah, Further work needs to be done to verify these findings in other clinics and locations, but at the very least, it's a start. Top surgery seems to be beneficial and not commonly regretted. But Schreier is focused on the second part of Olson-Kennedy's statement, that breasts can be acquired later in life if they're wanted. The plastic surgeon Schreier spoke to, Dr. Patrick Lappert, said that a mastectomy is not reversible. You can make a new breast mound, but it's just a lump on your chest which looks like a breast. Schreier then details some of the anatomy with the ducts, milk production, and erogenous function to say that eliminating biological capacities for aesthetics is wrong, and in any other area of medicine would be forbidden. This goes on for some time with many comparisons, like eye color or nose shape, to say how unacceptable it would be to remove the eyes or the ability to smell for aesthetics.
But in the case of an AFAB adolescent, surrendering their capacity to breastfeed so that they can appear to be a boy, that's considered morally correct. Forgive me for my skepticism.
Something that was highlighted in the full Olson-Kennedy talk was that the potential costs of the surgery need to be weighed against the benefits. Without the surgery, the person may be experiencing a lot of distress because of how that area of the body looks and feels. They may be wearing a binder to minimize things, but as Schreier likes to point out, there are potential health costs there. They may be socially withdrawn and/or not seeking medical help because of the chest dysphoria. This surgery isn't just about aesthetics, and claiming that it is underhanded. We're going to skip over Schreier shit-talking a Canadian plastic surgeon who does these surgeries until the next speed bump.
Interestingly, Dr. McLean and other top surgeons like him offer masculinizing double mastectomies to AFAB people who do not even identify as men. He provides them to those who claim to be non-binary too. Wait a minute, I pushed back. I thought the point of the surgery was to turn an AFAB person into a convincing man. What is the justification for cutting off an AFAB person's chest to turn them into a neither?
Is it surprising that Schreier wouldn't understand a non-binary gender identity and how that person may feel? Schreier goes the transmedicalist route, asking how somebody who's non-binary could experience gender dysphoria. Also, if people can self-refer for top surgery, how can a doctor know that they aren't performing surgery on somebody, quote, who is just having a nervous breakdown? I guess this is internally consistent with her argument that these youth are really just depressed or anxious. Doesn't make it any more correct, though. It's finally time to talk about what top surgery entails in this section on top surgery, with all the decorum Schreier has used throughout the book. Which means we're going to pass on her descriptions of the procedures and the results, other than to note her claim that the scars from these surgeries act as another trans badge, marking you as on the trans team. As with the cardiovascular risk from testosterone, I would guess that most people would probably prefer if they could have the surgery without scars instead of with scars. The last part of the section includes Schreier basically claiming she can tell when someone has had top surgery due to the size of the chest or results being not quite right. Part of her judgment comes from looking at the person's hips. The plastic surgeon Schreier was speaking to agreed with her that top surgery could make an AFAB person more dysphoric because they might appear more bottom heavy. But
Not to worry, I checked with a plastic surgeon. If they become dysphoric about their hips, there's a surgery for that.
of course, she thinks she can clock trans people. It's almost like a subtextual argument here is that these different procedures will actually give the person more gender dysphoria, so really, their best option is to just try and rough it out where they are. Which, again, completely ignores the person's wants and needs in the matter, or the lengths that some people will go to make their body feel right, like black market hormones. And you would think the surgery or procedure for feminine appearing hips would be something like lipo, but the next section's on bottom surgery. This section starts with Schreier reiterating the low number of people getting bottom surgery and saying that it's a good thing because of all the horror stories she's heard. You may recall Schreier discussing the rates of phalloplasty back in the first chapter, commenting that these youths not wanting to get the, quote, defining feature of manhood indicates they don't really want to be men. Same reference and stats. You may also recall the nuance from chapter 1 here, that the 12% wanting to have or have had a phalloplasty was for all AFAB respondents to the US Transgender Survey, so this included trans and or non-binary people. And if you brought in surgical options to metoidioplasty, the percent interested rises another 16%. And if you restrict it to only transgender men, the percentages change to 22% having had or are interested in phalloplasty and 27% in metoidioplasty. I'll also bring up the feedback I got in the comments section. There are plenty of trans and or non-binary people who would love to have a dick of their own, but aren't happy with the surgical options right now, so are holding off. We're going to simplify this section somewhat. Schreier describes in great detail how a phalloplasty or metoidioplasty are done, along with potential complications, in what feels like an attempt to scare the reader away from these surgeries. The sole reference here is to a plastic surgery paper detailing the then current state of the phalloplasty procedure. She has it attached to a claim about blood clots causing skin grafts to fail, leading to an unsuturable wound. I've been through this paper multiple times. The words graft and flap have lost all meaning. But I didn't see anything about Schreier's claim in here. Schreier shares the story of Blake, a trans man who transitioned in his 40s but experienced many complications with his phalloplasty. Doing a quick search, and I found a piece on this book that identified Scott Nugent as Blake. The hyperlink for Scott's name from that story takes you to his website, which is dedicated to trying to keep youths from medically transitioning. It's even less rooted in reality than Schreier's book, so just know that it exists, and this is who Schreier is speaking to. And just to be clear, I am sorry that Scott's surgery did not go at all well for him. It sucks to be a statistic in the rare complications column. Even speaking out about your experiences and red flags you encountered along the way is still helpful. It helps others understand the risk they're taking on and things to look out for. But championing for the removal of that treatment for others because of the potential risk, even when discussion of that risk is part of informed consent for that procedure, that crosses the line, especially when that championing involves misleading or incorrect information.
In some cases, of course, phalloplasty succeeds, but the surgery is so difficult to perform, there are many things that can go wrong. As selective surgeries go, this is certainly not one to take lightly. I'm no doctor, but the grisly stories I've heard from plastic surgeons and phalloplasty patients themselves have been more than enough to convince me. If there is any way on earth to alleviate your gender dysphoria without phalloplasty, it'd probably be a good idea to pursue the alternative.
Hey Schreier, you know all those treatments you've been shitting all over for the rest of this chapter? Puberty blockers, hormones, top surgery, metoidioplasty even? Those are other treatments for gender dysphoria. And the relatively low percentage of people who have gotten or are interested in getting a phalloplasty somewhat reflects Schreier's sentiment here. People are wanting alternatives. Just that not everybody is fixated on the dick as she is.
Testosterone is a Schedule III controlled substance, full of long-term health risk. Top surgery is an elective procedure that destroys biological capacity, and phalloplasty is full of serious risk. And yet, in the last decade, doctors and clinics began providing gender treatments like these without even requiring a therapist note. Why?
Schreier's explanation for why. First, the Affordable Care Act indirectly forced insurance to cover gender-affirming care. This made formerly expensive hormones or surgeries free or low cost. A man who had previously medically transitioned told Schreier that if the surgery and hormones had been more expensive, it would have made him consider things more and he may have avoided transitioning. That has got to be one of the weirder arguments I've seen for keeping healthcare expensive. I'll also take this opportunity to bring up the detransition responses from the 2015 US Transgender Survey Schreier will sometimes reference. Less than 1% of respondents detransitioned because they realized it wasn't for them. This person Schreier spoke to may have been part of this minority. And it would be great if we could figure out what's going on with that 0.4% to prevent this from happening. But in the meantime, in order to do the least amount of harm globally, that risk is taken on so that the other 99.6% can be helped. Schreier's reason why number 2. Because doctors have fallen in status, as indicated by the term healthcare providers. They are less likely to uphold the Hippocratic Oath. I think the shift in language reflects a more inclusive term for who is providing healthcare, so it's not just the doctors, but nurses, techs, and everyone else who keeps the medical ship afloat. Also, I'm not sure if she's talking about this oath literally. because in my understanding of how being a doctor works, it's not something that generally happens literally. Like, you're not sworn in on the Hippocratic Bible or whatever. Not sure if this is a subset of two or its own point, but things like the WPATH conference, according to Lippman of ROGD fame, have changed from being stuffy to more activist-centered. I don't know. Looking at the welcome letter for the 2019 US WPATH conference, it seems like there's a lot of poster sessions and talks. Granted, there is a town hall mentioned for dialogue between professionals and the attending public, but for this topic, that isn't a bad thing. Although, Schreier seems to err on the side of keeping treatment gatekept, so this would be bad to her. Finally, doctors have become trans activists themselves and don't discourage patients enough. This leads to the possibility of creating a person who is dependent on medication and ongoing surgeries. To repeat something I've said in a slightly different version, if we could get an AFAB body to produce enough testosterone, the medications wouldn't be needed. But we don't have that ability yet, so some people need testosterone medications. And despite her repetition, Schreier has not supported this idea that a person who has one gender-affirming surgery will continue to just get surgery after surgery for the rest of their life. There may be a series of procedures, sure, but at some point, most people will run out of things they want to tweak. Alright, let's end this chapter.
The dangers are legion, the safeguards absent. Perhaps the greatest risk of all for the AFAB youth who grasps at this identity out of the blue, like it is the inflatable ring they hope will save them, is also in some ways the most devastating. That they'll wake up one morning with no breasts and no uterus and think, I was only 16 at the time, a kid. Why didn't anyone stop me?
I feel like a broken record. The dangers should be covered in the informed consent process for any of the treatments. While the medical gatekeeping for gender-affirming healthcare has been chipped away at, there are still safeguards in place. Most people don't spontaneously decide to be trans and/or non-binary out of the blue or in an attempt to deal with depression or anxiety. And finally, the regret rate for transitioning seems to be low. But guess what the next chapter is about? I don't think any of this chapter was particularly surprising, although it is interesting that the extra work in trying to hide the gender-critical ideas seems to have been largely abandoned at this point. To try to get something positive out of this, a takeaway may be a sort of medical caveat emptor. When you are thinking about starting a treatment or getting some sort of procedure, do your research. Do not entirely rely on the healthcare provider to adequately inform you of the risks or possible side effects. If you can come into an appointment with a set of questions about negative outcomes you might experience, you stand a better chance of being fully informed. And if the healthcare provider shuts down discussion or just waves away your concerns, that is a red flag that you should not ignore. But I know having a choice between providers in the sector of healthcare is a regional luxury, not a given. And so if you're considering these things, you may have to weigh the costs and benefits of getting it done locally. And yeah, that's enough for this video. Until next time, bye!